Hi, everyone. I'm Scott Allen. I'm the CEO for the Family Medicine Education Consortium. Um, we are here today to hear from Dr. Daniel Hoefer about geropalliative care. Um, Hopefully you all can see and hear us. And I've asked you to kind of introduce yourselves in the chat to see who we have on. I see Dr. Borelli has introduced herself. I'm actually going to unmute the attendees so that you're able to share with us if you'd like why you're here and what your interests are. And we should have a few more people joining us, but why don't I go ahead and get started with introducing Dr. Hoefer, and then he can have his presentation and we can have some time for questions at the end. So thanks everyone for joining us. Dr. Hoefer is the Chief Medical Officer for Sharp Healthcare's Outpatient Palliative Care Program, Transitions, and he's Associate Medical Director for Sharp Hospice Care. He's a family physician certified in palliative medicine and part of the Sharp Reese Steele Medical Group in San Diego. He received his medical degree from Eastern Virginia Medical School and completed his residency at Northridge Family Practice. FMEC is really pleased that we were able to work with Dr. Hoefer to develop this geropalliative care series that we're now offering. We've been committed, as you all know, probably to innovation and high quality care, and we've done a lot of education at our annual meeting around palliative care. So this dovetails very nicely with what we want to do. So we're excited that we were able to launch the online series on our website last month. And today we're going to hear a case study from Dr. Hoefer and have some time for your questions about the case study, about the course, about the content. So with that, take it away, Dr. Hoefer.
Yeah, thank you very much, Scott. And I'm going to go ahead and give a very brief explanation about how I came into developing this series. Being board certified in palliative medicine and as a family physician, there's actually a gap between those two spaces, and that it still exists today. Most of the patients who fell into exclusionary criteria in research are not well investigated. And until they get to the point where they actually need palliative or hospice care, there's a massive gap in our knowledge base in healthcare. And with the fastest growing populations being in that demographic and age groups over 75 and 85, we have some work to do to fill in that space to finish the job, the entire bell curve. Geropalliative medicine does three things. Number one, it makes sure that the care that we are providing is consistent with the goals of care of the patient. So that's truly patient-centered care. And you're going to see if you take the course how we're not quite there, at least not as close as we think we may be. And number two, the clinical guidelines change for the advanced elderly population. Blood pressure, hemoglobin A1C, cholesterol, all sorts of metrics change that a lot of people are not aware of at the present time. And we need to get better and more robust data, but our professional societies are starting to recognize that. So they are changing their clinical guidelines. This is unlike population health. Population health did a great job on what I call the left side of the bell curve, capturing those patients whose blood pressure, cholesterol, hemoglobin A1C is in the wrong area and they need to improve it. But on the left side, right side of the bell curve, we need to also make adjustments, and people need to be aware of that. And last and perhaps most importantly is we need to understand geriatric syndromes in the context of the care that we provide. Because geriatric syndromes are defined by the principle of double effect, that you can't fix one organ system problem without making the geriatric syndrome worse. And this is only one case I'm providing today. I have about 8 to 10 presentations I can do, and this is just a case study, which is one of the very quick and easy ones. But to show you patients we see every single day, which family physicians, primary physicians, but frankly all specialists could improve their care. So I'm going to go ahead and share my screen and just tell me if you see this. I just want to make sure everybody sees this. Can you see that, Scott?
Looks great.
Okay, so I'm going to start this case. This is from my medical group. It's a real case. I give these at the beginning of the year because there's new doctors and we need to learn how to do a better job managing patients everywhere. Let me see, how come it's not? There we go. So this happened to be an 84-year-old female, came in to me for confusion and hallucination. She was fine at the time I saw her. She came in with her daughter. Now, I do consultations from my colleagues from both internal medicine and family medicine. Sometimes they forewarn me these patients are coming. Sometimes they just show up on my office, and this was one of those patients that just showed up. I had no advance warning what they were coming in for. Daughter told me she just wanted somebody to tell her, quote, what's going on? What's going on with my mom? The mom herself states she'd been in the ER twice and had nothing's ever found. Recent episode of hospitalization was precipitated by 12.5 milligrams of diphenhydramine Benadryl for itch that had been started by the patient's husband. She was only taking 1 or 2 a day for that itch. She was a new patient to my medical group from 2 years ago, had a history of headaches and dizziness, no stated history of dementia, but acknowledges that she was becoming a little bit more forgetful. It was getting worse over the last couple of years. You know, we see that all the time. Our patients say, oh, I just can't remember why I went into the room, or I'm not remembering names as well. As she fell 2 years prior and was hospitalized for a complex hip fracture and a wrist fracture, and 3 hospitalizations since for confusion for which the workup was negative. Now, this is the patient's, you can see her BMI, and this is the patient's medication list. So knowing what I just showed you, far and away, what is the single most important question we can ask this patient or the daughter? And the answer is, was your mother confused in the hospital? Because the medical condition, the geriatric syndrome of delirium, is highly prognostic of future outcomes over the next several years. And in fact, this patient clearly had hospital-induced delirium. She had all 5 characteristics of the confusion assessment model. But the bigger issue is that nobody had discussed the meaning of hospital-induced delirium with the patient or the daughter. And this patient had seen at least 30 physicians since being discharged, both patients in the emergency room, hospitalists, outpatient physicians, and nobody had taken the time to explain to her what it meant to have developed hospital-induced delirium. The next question you need to ask as a primary care physician in your office is, what is the patient's ACB score? And for those of you who don't know, ACB stands for anticholinergic burden. There are multiple anticholinergic burden tables on the computer. You can look them up. They're all patented, so you just have to realize, look at those ones and decide what meds you're using. If you want to get a feel for what the score of your medicines are, you can go to acbcalc.com on the computer, and that will give you a score for the medicines you use. Different parts of the country use different medicines, so I just say get used to what you're using and consider moving your meds to something that's less anticholinergic. But it's not just anticholinergic medicines we have to worry about with the geriatric population. You also have to ask how many psychoactive meds is the patient taking, and does the patient have polypharmacy? And the other question, very uncommonly asked, is the patient actually depressed? Because a lot of our patients are getting put on antidepressants when they actually are having hypoactive delirium. And I quote one study that showed that 42% of hospitalists who referred their patients to psychiatrists in the hospital showed that those patients did not have depression. They were referred for depression, but they actually had hypoactive delirium. So next question, of course, the patient's husband had given the patient diphenhydramine. What's the ACV score for diphenhydramine? It is a highly anticholinergic medicine with a score of 3. Any total or single medicine with the score of 3 or greater is considered clinically significant. So if you go back to this patient's medication list, let's look at that list. Duloxetine, melatonin, metoprolol, midodrine, Prevagen. Number 1, the patient has, the metoprolol has an anticholinergic burden score of 1, and the Benadryl has a score of 3, so now the patient's score is 4. That's number 1. Her ACV score is 4. She has 5 medicines, and they are all psychoactive. So she has polypharmacy and a high psychoactive burden. We can decide whether we actually think Prevagen is psychoactive or not, and melatonin is actually protective of cognition in some studies. But the reality is we have to look at this medication list, which I thought was funny anyways. Patients on half a tablet of metoprolol seems like a very odd dose, even if it's being used for chronotropic benefit for AFib or something like that, and not sure that the duloxetine was actually necessary. So This patient had the confusion assessment model evaluation. This is the standard international evaluation for delirium. You have to have 1 and 2 plus either 3 or 4. This patient had all 4. The daughter told me she called her mom in the hospital, and this was during COVID, so it was on a computer video visit. And the daughter said, well, she was totally out of it. She didn't know who I was, especially if I called at night, so it was worse at night. And she was alert prior to going in for her hip fracture. She couldn't pay attention. She was all over the place with disorganized thinking, and she was hyperactive. So she had 4 out of the 4 characteristics. One of the things about fluctuation too, don't perseverate about whether it's hours or in the same day. Patients can fluctuate over weeks. So a lot of people get caught up on that. Well, it's not fluctuating, so it's not truly delirium. If it was, patient had normal cognition the day before and now they've changed their status, that's fluctuation. The prevalence of delirium is incredibly high, which is remarkable that we don't actually make the diagnosis more frequently. And I've worked in all of these arenas in hospice, in the ICU, nursing homes, hospitals. So I see it frequently. Hip surgery is up to 65%. So we should be expecting that, especially in an elderly population. Even cataract surgeries, by the way, a lot of people don't know even minor surgeries can do this. TAVR, 25% of patients develop delirium. And I bet you most people are not looking for delirium in their TAVR or cataract surgery patients. So one of the questions, of course, you have to ask then is delirium the precursor for dementia? And that's one of the questions that's been asked over the course of many years. And in my course, I show you how there's a growing connection between delirium and dementia. This was just one study showing orthopedic patients, no pre-existing cognitive hearing visual deficit, went for known hip or knee replacement, 60% fractures, 25% elective repairs. But in those that developed hospital-induced delirium, they were 10.5 times more likely to be diagnosed with dementia in the next 5 years. In a meta-analysis of research articles such as this, hospital-induced delirium was associated with a 12.52 times greater risk of dementia in the next 4 years. So that's any patient who's developed delirium, we need to start having a radar up that these patients are high risk for dementia and should be constantly screening them with mmscs or MOCAs or slums tests to be sure that we haven't caused or exacerbated brain failure. I don't want people just to think that delirium is only associated with cognitive decline or dementia, however. This was a 3-year prospective study, pre and post-op evaluation, so pre-op then 8 months and 38 months for people 60 years of age and older. When you look at these research articles, you have to look at the age they started the evaluation because it will affect the percentage outcomes, but this is a younger population. They were excluded if they had dementia or pre-op delirium. 200 patients, 41, typical number, about 21% developed delirium, 74 years of age, mostly women, some fractures, but in this case it was 72% were elective procedures. This is why we have asked, according to the National Surgical Quality Improvement Program, that all patients prior to surgery be screened for cognitive evaluation starting at the age of 70. And for a patient who develops delirium, of the 33 patients who died, almost all of them were delirious patients. They were 3.5 times more likely to die than non-delirious patients. Of those survivors, they were 5.5 times more likely to have severe functional decline, meaning that even if we fixed their problem, these were the ones in a walker, a wheelchair, or bedbound. And that's more than half of our patients, which is why we need to screen for patients who are likely to develop delirium. And cognitive impairment was 14 times higher. And this is why we see so many of these patients, even though we can fix their hip or fix their knee or fix a hernia, principle of double effect means that we're going to impair their geriatric syndrome or accelerate their geriatric syndrome. So there is some interesting literature coming out as well. People don't know about the elderly population. This is the consequences of just using the ER in hospital. This is just a case study. I'll show you several articles that show this in my series, that every time you send an elderly patient to the hospital, you accelerate their cognitive decline. And that is even for patients with normal cognition, such as you and I. And now that I'm 60, I'm worried that my physicians won't know about this type of research. But this was a validation study that was done in Germany. The original study was done earlier in the same year in the US and almost showed the exact same things. 60 years of age and older, 4,500 patients. You can see normal cognitive decline. This is a different cognitive decline scale. After the first hospitalization for a population of patients, if the patients use the hospital, cognitive decline more than doubles, and almost triples. And after the second hospitalization, it quadruples. So the default position in cavalier nature for which we use the hospital as a tool to manage patients needs to be reevaluated or at least discussed when you send your patients electively or not to the hospital. And that's a graph looking at that. You can look at patient 1 and 2, or you can look at patient 1 as when they're 60 and patient 2 is when they're 80. First hospitalization is the red line. The bottom line is when the second hospitalization, and normal cognitive decline would be on the top line. But you can see somebody at risk who has too many hospitalizations, we actually push them into mild cognitive impairment and eventually into dementia. So back to the patient in my office, what do you do next? You must perform an MMSC or a MOCA or a SLUMS. Now you have to send $1 to Canada. MMSC, you send $1 somewhere in the US. I don't know. When they ask me where to send it, I'll send $1 for every MMSC I've done. It's worth it to me to know that I've done the right thing for my patients and given them the right information. By the way, the MMSC, I've memorized it, so I can draw 2 pentagons. Everything else are simply questions, and I can ask those questions without using the form. That's why I use that, because I can't draw rhinoceroses and animal figures or do the 1A, 2B testing. It doesn't work very well. I look back at the patient's ER notes because she'd been in the ER so many times, and her ER notes said alert and oriented times 3, normal mentation, no cognitive deficit noted. These are on different ER visits. So what MMSC score do you think this patient had? Somebody give me a number, and some participant give me a number. Anybody? I can't see the chat box, Scott. Is there something up there? Do you want to give me a guess?
I see 21 in the chat.
All right. This patient had an MMSC score of 9. 9. And this fooled dozens of physicians. And that's how serious this problem is. And you have to ask the question, why didn't anybody check? I was the first physician in 2 years to quantify brain failure. Now we quantify renal failure, hemoglobin failure, heart failure, pulmonary failure. We call that acute on chronic heart failure, acute on chronic renal failure, acute on chronic pulmonary failure. But who's looking at acute on chronic brain failure? And what's interesting is the 2 issues, patient-centered care, that our patients care about most are maintaining their cognition and maintaining their general functional ability, because that leads to autonomy. Yet those are the 2 things that we tend to evaluate least. Now you have to ask the question, how can that be? How can a patient with an MMSE of 9 go unnoticed? And I can tell you that an MMSE of 9 is equivalent to about a 5-year-old's cognition. They are capable of answering simple questions. When you ask, where are you, or what year is it, especially if they've been asked that question multiple times, they're very likely to get it right. But the domains of the MMSE are multiple. And if you don't look at all of these domains, you're going to miss the fact that this patient has a very low score. I remember one patient I had recently who was an engineer, and he did horrible on the MMSE, except when I asked him to do the visual construction of reproducing 2 pentagons, it was immaculate. The computer could have done it, because that's the part of his brain that was functioning well. The part of this patient's brain that was functioning well was the orientation and repetition component, and that is frequently the domains for which we use when we're talking to our patients in normal conversation. So we have to look beyond that to see if they actually have cognitive impairment or dementia. So what do you need to do next? Still in this first visit with me, you can think to yourselves what the answer is. You have to do labs and a CAT scan. So I could look on my chart and see that this patient had the appropriate laboratories. I'm not sure, they were done in the last year or so. They weren't done all at the same time, so I'm not sure anybody was looking specifically for reversible care. And thyroid and B12 are rarely found as true reversible care issues, but it's good to look. I also looked at hemoglobin A1C, electrolytes, hemoglobin. But some of those things can cause confusion, calcium, magnesium. They're very rare, but they do happen. And the other thing you have to do is you have to consider doing a CAT scan. So I told the patient and daughter, well, I think let's order a CAT scan. And then the daughter said, well, the patient's already had a couple of CAT scans. And our computer systems aren't synchronized, so I did a read-only version of the hospital system. And what did I see? In the last 2 years, because nobody had looked back to have a discussion about what was going on with this patient, every single time she went to the emergency room, she got a CAT scan, and she had had 12 CAT scans. 12, one every 3 months on average. So the progression of her cognitive decline was defined by a healthcare system that nobody took the time to develop a discussion about delirium and the inevitable consequences of the progression of that diagnosis. This is massive overtreatment. So here's more of my visit. So the next thing I did, now that I've determined that she has dementia, was I used the staging tool. And I rarely see primary care or physicians, even my neurologists don't use this frequently, is the FAST staging tool. It's a function assessment and staging tool to tell us where the patient is in the anticipatory guidance for demented patients. And this patient was a FAST 6D, meaning that she really couldn't put her clothes on properly. She was incontinent of urine. The next stage is a FAST 6E, where they become incontinent of stool. A lot of people think of dementia as only a cognitive issue, but it's actually a cognitive, functional, and physiologic issue. And you can follow these things over time to provide anticipatory care to your patients. She had complete IADL deficiency and 5 out of 6 ADL deficiencies. And here, in fact, is an example of the FAST staging tool. The other part of this tool is that it's associated with longevity. So I already knew from prognosticating using her delirium, but the fact that she was a 6D, that she was in the last couple of years of her life. And that's evidence-based research that shows that. So I went back into the Cerner system, which is our hospital-based system, and I saw prior to her coming to our medical group, the patient had seen a neurologist and was receiving occipital injections every 4 months for her headaches, cervical injections for occipital headaches. And some early cognitive decline was noted, but she wasn't particularly diagnosed with dementia at that time. The estimated cost of these last 2 years of care of overtreatment, because nobody had talked to her about what was going to happen and why, overutilization of the ER and the hospital for something we should have had a discussion on earlier, was somewhere between $250,000 and $500,000. That I was a utilization manager. I can pretty much guarantee that was the cost of her last couple of years of care. So the take-home message for this particular case study is, number one, of course, review all records. But from the gero-palliative course, we need to understand geriatric syndromes. When you understand 3 in particular, delirium, frailty, particularly the Fried-Hopkins version of frailty, not the multiple other versions that are out there, and sarcopenia, you'll markedly improve your care for your patients. Understand that geriatric syndromes are defined by the principle of double effect. You can't fix one thing without fixing the other one. And we may actually be making our patients demented, and that's something we need to have greater awareness of, because we use a lot of anticholinergic medicines, a lot of psychoactive medicines. We don't effectively address polypharmacy. There's way too many surgeries, in my opinion, too many ERs and hospitalization visits, and that's shown by this patient. Lack of awareness of that principle of double effect that needs to be something that's institutionalized in our practice. We need to be using anticipatory guidance. You know, I talk to my internal medicine colleagues, and they're not as used to that as family physicians, because we were trained with pediatrics. This is, you know, it's not acceptable to have any child ever drown. So we use anticipatory guidance to keep that from happening. But we can do the same thing for all of the chronic diseases, the inevitable consequences of the natural progression of disease. Have an extremely low threshold. Make it institutionalized that virtually every one of your patients at some point gets a cognitive evaluation. We wouldn't think twice about doing a kidney evaluation or a hemoglobin or a EKG, but what about the patient's cognition? And stage your demented patients It does help them in understanding what comes next and to be emotionally prepared and using some anticipatory guidance. And my last comment would be, don't default to the emergency room or hospital believing your patient will get better care, have a better outcome, or that there is no harm. One of the things we rarely talk about in healthcare is the 23 known harms of sending a patient to the hospital. And the demographic that's most at risk for that is the advanced elderly population. That doesn't mean you never send them, but there are certainly a number of times when it can be extremely concerning and harmful. So that's a particular case study. I took that to my group because that's one of the consultations I did. I hope that's helpful in understanding what I'm trying to do. This is only one geropalliative scenario. There's multiple. So any questions or discussion, I'm happy to hang around for a few minutes and answer those.
Yes, thanks, Dr. Hoefer. And if anyone has questions, please go ahead and unmute yourself and ask.
So let me ask you, are there any questions, Scott?
I don't see any right now.
So let me ask the group, how many of you would say that your primary medical group has institutionalized the process of doing cognitive evaluations starting at age 70 or at some point, or are following the National Surgical Quality Improvement Guidelines to do an mmsc or a MOCA or a SLUMS prior to every single surgery, even minor surgeries for people aged 70 years of age and older? Is anybody doing that? No. Nope, I see somebody's hand up. Maya or Raleigh? Did you have a question?
Dr. Anderson had replied in the chat that they do not do this.
Yeah, and this is why I chose this case, because if you don't even take my course, if all you learn today is the value of protecting our elderly population's cognition and realizing that that is a massive warning sign for us as physicians about what's coming next, that would be great value in improving the quality of care for your patients. Has anybody ever heard of the FAST staging tool, and do you use it? And how about the CAM, confusion assessment model in the outpatient environment? Lots of opportunity.
Yeah. Other comments in the chat that they don't use that either. Dr. Raleigh, I think you unmuted. Did you have a comment or question?
No, I'm so sorry. No.
Okay. All right. Well, I hope that was helpful. You can see what the course is designed to manage, and you can see how much opportunity exists. And just think of that. In all of our population health, that was for the people who were included in the research. What I'm talking about today is all of the patients who were excluded from research. And if you come to my next presentation that I offered to do, I'm going to show you some interesting things about blood pressure management you've probably never seen before, because right now we're rallying around the SPRINT study, but maybe we need to put the brakes on a little bit, because there's a lot of data that says that is not applicable to our elderly population, and I can show you why.
Well, thank you so much, Dr. Hoefer. It's very interesting, and I'm hoping that we have a lot of people engage with our series to learn more. I think everyone on the Zoom webinar probably can find it. It's on our website, fmec.net. And if you have any other questions for us or Dr. Hoefer, please feel free to reach out to me and we can make sure to pass those on. So thank you so much, Dr. Hoefer, and thanks everyone for joining today.
Great. Thank you so much, you guys. Have a nice day.